Welcome, everyone. My name is Ross Goldberg. I'm the current chair of the Board of Governors for the American College of Surgeons. I'd like to welcome our guest, Dr. Charles Mabry, who is willing to share his time and expertise with us regarding some clarification on the recent anterior abdominal wall hernia code changes. Dr. Mabry has an extensive leadership history with the college, former first vice president, former regent, was the founder and chair of the Health Policy Advisory Council, and has been an advocate for us for many, many years. He currently still sits on the General Surgery Coding and Reimbursement Committee and is here to answer some questions about all the changes that have occurred this year regarding these hernia codes. So, Dr. Mabry, thank you for being here.
Oh, thanks, Ross. I appreciate having a chance to visit with everybody.
We appreciate your expertise, and I know you've already been very active on the communities and elsewhere, along with your colleagues, to provide some information. What I'm going to do is ask a few kind of pointed questions to give you the opportunity to help us further understand why these changes occurred and what we can do. So I'm going to jump right in with the first question is, why were these hernia codes changed in the first place?
Well, that's the most commonly asked question, I think, from all the communities, and also phone calls with the different fellows. So let me just explain a little bit about how we get a value for a code and where that comes from. It turns out that that under the law in 1992, the Congress set up a new system for payment, going from the old usual and customary to the resource-based relative value scale. And the thought was of Congress to pay people for the work they did and for the practice expense that they use and for the malpractice. And so we currently, many years later, are still on that same system. Part of that system was the fact that there was a conversion factor that every year was calculated based on the utilization from the year before. And we started out in 92 with about $34 per RVU unit, relative value unit, and it's still around $34. So we've not had a raise in all those years. And if you don't like that, talk to Congress. Your congressman is in charge of that. And of course, the college has been very active, very proactive, along with Ross and others on the advocacy side for that. But we have to remember that between the legislative branch, Congress, and the executive branch, and in this case, CMS, those are really the two people that control payment to physicians and how we get paid. And so we have to work both on the regulatory side, and the college is very active in that. And we also have to work on the legislative side with advocacy to try to get us paid better. Well, the method by which CMS measures work, relative value unit of work, is actually has input by the AMA RUC and the specialty societies. There's many societies that belong to the RUC. The college is one of them. There's about 34 members of the 32 physicians that sit on the RUC and vote. But our vote at the RUC is just our opinion that we send to CMS, and they don't have to take it. They actually submit a final rule every year in which they decide on the final value and also the conversion factor. But the college has a very good representation at the RUC and also at the CPT editorial panel where these codes come from. So codes come from the editorial panel, CPT editorial panel. They go to the RUC for evaluation, usually through a survey. We do a survey of the fellows, and they tell us how much work there is involved, how much time it takes. And we present that to the RUC, and then we present those values from the RUC to CMS, and they hopefully will take our suggestions. Well, back to the hernia codes, the abdominal wall, ventral wall hernia codes are some of the most commonly used codes by general surgeons. So it was really top of our list of things to be watching for. And CMS is set up for the RUC to reevaluate codes from time to time to make sure that the value that's in that code still remains the actual value, that things have not changed. And therefore, they have screens that are set up. Very frequently used codes are reviewed commonly. Codes that were in inpatient and now have moved to outpatient are also reviewed. And in our hernia code family, we had several codes that hit the screen for moving from inpatient to outpatient use. Well, part of the rules that CMS sets up and the RUC sets up is if you have 2 or 3 codes in a family of codes, the whole family has to be reviewed. The whole family has to be surveyed. Now, many of our hernia codes, the old codes, were old codes 20, 25 years old. And as you might imagine, technology has changed. People are now doing much larger hernia repairs than they ever could before. Anesthesia is a lot better. Length of stay is shortened. So since the value that goes into a 90-day global, part of which depends on the length of stay in the hospital and also how many office visits afterwards, we actually anticipated that we were looking at around a 20 to 50% cut if we just did nothing and just resurveyed the codes. We didn't have an option to not survey the codes. That was a mandate. But we also could see that we're going to have a 20 to 50% cut in those values if we were to keep the old codes and just present them back to RUC. Well, the other factor that came into being was the fact that through many different sources of input, the college, the Coding Reimbursement Committee also has members of SAGES there, American College of Academy of Colorectal Surgeons, ACRS there, and we have input from the Hernia Societies, many other things. We have a lot of input. And along the way, what we kept hearing from the fellows out there was, we're doing larger and larger hernias, and we're using different techniques, robotic, laparoscopic, and combined approaches. Therefore, taking all those things into account, the committee felt, based on protecting our codes and trying to get the best value, that we would go to a 0-day global and then redo the codes so that we could take into account the fact that codes are now being, hernia repairs are now being done in larger and larger hernias. One of the things to remember, the old codes were not size specific. It's just if you did a huge ventral hernia or a 3-centimeter hernia, it paid the same. The newer codes really pay the fellows. The larger the hernia, the more work there is. We actually pay the fellows more, or their RVW value is more, and therefore it's a fair system. The other thing we heard from a lot of surgeons around the country was, well, if I start with a laparoscopic approach and then convert to open, my hospital makes me bill the open code, which actually paid less. So we tried to make these codes procedure agnostic. Whether you start with an open repair, close things up, and then convert to a laparoscopic approach, or vice versa, then it doesn't matter. The coders are not trapped into trying to decide if it was an open or closed or laparoscopic robotic code. So we did a lot of improvements in the codes. We actually had some new codes that we added about formation of hernias or repairs of hernias around ostomies, some other things. So that's kind of the reason why we changed the codes, was to protect the codes, but also give us better values for the work that we're doing.
Well, that makes sense. So, but let me ask you this. So why couldn't we just tell CMS, no, we don't agree with what they're doing. We don't want them to make the changes. We're the ones doing the work. Why were they able to, you said you were mandated to do this. Like, where do they get that authority to mandate such a change? Why couldn't we have a stronger pushback against this?
That's right. Well, now the college does have good input to the RUC. I will say this and reassure the fellows, Lauren, Vanita, other people in the DC office spend a lot of time writing comment letters back to CMS for the proposed new rule and other proposals they put out there. And we meet with RUC, we meet with CMS on a infrequent but regular basis. And so we do have input, but you have to remember that surgeons are a very small percentage of all the physicians in the country. General surgeons make up about 2.7% of all physicians. Primary care specialties, let's take them as an example, make up around 66% of all physicians. So there's a lot of input into CMS, and we're just one source of input, and we don't have much control over CMS. They decide what to do. So the way to influence CMS is to get data that we can present, done through the surveys we send out to fellows, go to the RUC, argue for a fair value, and that carries much more weight than us by ourselves as one specialty going to CMS and saying, you guys don't understand this. You get it all wrong. Listen to us, because they're not going to do that.
Fair enough. But let me go back to something you brought up during your explanation of the codes. Speaking as a minimally invasively trained surgeon, I do laparoscopic, I do robotic. I have many colleagues who do robotic, these complex hernia repairs now. So there is this concern that they're doing these longer, more complex repairs, because there is a difference even from doing, a 5 centimeter open, say, repair versus 7 or 8 centimeter, complex robotic repair, and that's still within the same size category. So they're worried about doing these complex, minimally invasive hernias, outpatient setting, or just an overnight stay, and they feel that they're getting paid less for doing more work, right? Those are longer cases that still work intense for the surgeon. How do we kind of rectify that issue, that there's this idea that now you're doing more complex MIS things in the outpatient setting, but are getting paid less, even though you're spending several hours in the OR operating on these patients?
Well, no, that's exactly what we found out. And that's why we surveyed a broad spectrum of the fellows out there, many of which are now doing advanced robotic and advanced laparoscopic surgery. And we got a fair amount of input from them, and those values, their operative times, their values that they suggested we use using a relative value approach. That actually is what formed our recommendations to the RUC. Now, one of the questions that's come up on the communities is, well, how do we decide the size? There's less than 3, there's 3 to 10, and greater than 10. We actually looked at data from the published literature, as well as the experts on the panel. Many of the people that sit on the coding reimbursement committee do complex hernia repair, so they're not novices to it. And so we use the existing literature, as well as the frequency of those different size hernias, and the expertise of the committee to kind of pick those cut points for the hernia repairs. And it's a bit of a judgment call. We could have had 5 different sizes, but once again, you're having to struggle to get a fair value for the smaller codes. That's usually the struggle. Everyone's a RUC and CMS can understand a big hernia. Well, that takes a lot of time, but it's trying to explain the complexity of fixing a relatively small hernia, let's say 6 centimeters, why that's twice as much work as a 3 centimeter hernia. And so we have to rely on the surveys of the fellows to really inform us of, well, what do they think? What's their time? One thing we have to remember when we present the RUC is that CMS sits there with a huge database. They have anesthesia records. They have billing records of whether the patient was done inpatient, outpatient, how long they stayed. So they have a fair amount of knowledge to kind of test what we tell them. And so the college has always tried to be very honest and very straightforward in our presentations, so that if we say something, that you can pretty well rely on it, that we're not just BSing, we're actually trying to tell the right thing. But the other thing to think about is that the old codes, the existing old codes, had many hospital day stays and had many office visits embedded in there. And those, when we surveyed, keeping the old codes, would all have gone away. You're right. Most people will do a hernia, and for the most common hernias, they'll stay one night in the hospital and then are seen back once or twice in office. So that was where the danger to us was the devaluation using these old codes that had no way to explain a big hernia versus a small hernia. So we decided to reconfigure the hernias into size, and also whether it's a reducible, incarcerated, strangulated, or recurrent. So those are the variations we added in there that were not in the old codes before.
So just to kind of to make sure I understand it too, because I'm sure others will ask. Basically, I think there was an assumption made from the previous codes that the work RVU number was higher for the work you're doing, and they're forgetting that all the visits were built in. So the actual number that was affiliated with the actual operation wasn't as high as people thought, because the numbers from those previous codes was a combination of things. When you do something like a 0-day global, now you focus on each act, if you will, and that's why you got to the numbers you got to. But of course, you made one suggestion. It sounds like CMS went a little lower than that in the end, because as you said before, they make their own decisions. Do I have that little summary correct? Is that a good way of looking at it?
That's right. At the RUC, the previously surveyed code, if you're changing one to another code, they have the data in front of them of what the old intraoperative time was, how many visits were in the hospital and what level, and how many visits in the office. And so what CMS has done, and this is where the risk to us was, they've just used simple math to go in and subtract those out, say, well, now poof, your 0-day code, and we're just going to subtract this value from your code. Well, if you look at the intraoperative work in the old codes, it actually was undervalued. When surgeons value a code, they're looking at other 90-day globals. And so they tend to, our experience has been, they tend to undervalue the work they do in surgery because there's more value that's added for the post-op visits. And so our real danger was that CMS would just subtract it out in just pure math, and we'd be left with intraoperative values really less than an appendectomy. So it was really a big threat to us. And we think now, if you were to compare the old intraoperative work versus the new intraoperative work, we actually increased the value that was being paid to surgeons for doing the surgery itself. And then, of course, you can bill the E&Ms. The other thing to remember is CMS increased the E&M values for office visits, but did not increase those in the intraoperative global. So the 9-day global codes are using the old lower E&M values, and we never got a raise from that or bump up. That's part of the prejudice that CMS has against proceduralists. So by going to a 0-day global, we're now billing at full ticket for the E&M visits, hospital and office, and we're getting a better intraoperative value than we would have had they just done the math and subtracted out the post-op visits.
Gotcha. And then, so I have one kind of final question. We talked about them, but let's talk about our patients. So how do we really explain this to our patients that now, when they come to see us for our post-op visits solely for these hernias, right? Because everything else is still 90-day global. So if I operate on someone for their inguinal hernia, that's kind of covered in the original RVU coverage. Now, how do we better explain to our patients that if they get an umbilical hernia fixed, they're going to have to pay for their post-op visit? There'll be a copay or something that is now in place compared to before. How do we best educate our patients so that we make sure we actually are following up and they're seeing us?
Oh, that's very important, Ross. I think most practice management lectures and most practice management consultants will tell any surgeon that the education before the surgery is done is just or more important than trying to collect the bill afterwards. And in today's time, what we're seeing is very huge deductibles, $5,000, $2,000 that the patient hasn't met. So the first thing to talk about is how to educate your patient before the surgery that this large bill will be due, and it's going to come out of their pocket, not their insurance company. Now, the post-op visits can be handled just the same way. You can say, now for this procedure done by Dr. Goldberg, when we see you back, there'll be a small charge for the all the supplies we use and him seeing you and making judgments and everything else. And that'll just be added to the larger bill for the hernia repair. And so just explain to him on the front end what to expect. When most people go to the physician's office, primary care physicians, they expect to be billed. They expect to pay right up in front. So the surgeon should be no different. It does get confusing more, I think, more so for the surgeon. You think most people come in a surgeon's office, they may have one operation their entire lifetime. And they don't have a reference of, well, I had 5 inguinal hernias and 4 ventral hernias, and the payment was different post-op. They don't know that. And so I think good education on the front end of what to expect for payment, or with the charge and what we expect for payment, helps everybody, the surgeon, the surgical practice, and also the patient.
Well, that's very helpful. I appreciate that, Dr. Mabry, and I want to thank you for taking the time just to kind of answer some of these questions. I do know and want to remind people who are watching that there have been other webinars and other slides and information that you and other people have put out from the Coding and Reimbursement Committee that we can link within this video format, so people can go review those changes. I know there's different scenarios they talk about, the idea that component separation is still under the 90-day global and how that works. So there are resources that the ACS has so people can kind of follow up and understand the changes that have occurred. Is there any kind of summary you want to give before we kind of conclude the video?
Ross, I think the main thing is just to reassure the fellows that our various committees, including the Coding Reimbursement Committee, works very hard. We're all volunteers. We don't get paid to come to committee meetings, et cetera, but we work hard to try to do things the right way for the fellows out there and for the surgical patient. But if there are questions or suggestions how to improve things, please just email me, call me, call anyone, call Christian Chalgen, call you. Because we do want to hear from the fellows, and we do understand practice. I'm in practice, you're in practice. We understand all this is just the life we live in, but we are trying to do the best we can. And to some extent, a lot of what we do is more damage control than raising everyone's salary. But we do try to do the right thing and try to get the best value for the surgeon that's possible.
Well, I thank you for all the time and effort you put in this. It's complex stuff. We were just scratching the surface here, and we can really get lost in the weeds if we wanted to about all the different nuances involved. So, as a reminder to kind of all of our members, all the fellows, participation is important. So, when we reach out asking for your help, whether talking to CMS or your member of Congress on these issues, please open those emails, please send those messages, because it does have a direct impact on our ability to influence these processes, as you've heard about. With that, I want to thank everyone who took the time to watch this. Thank you, Dr. Mabry, for your expertise and for your insight. And I wish everyone a wonderful day.